So, welcome to another Puscast, to review the infectious disease literature for the last 2 weeks of January 2009. This is brought to you, as always, by Pusware LLC, the publisher of the Persiphages Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your Uber hyperlinked electronic guide to infectious diseases at Pusware.com. Remember that all the opinions of this podcast are those of Pusware LLC and not the opinions of anybody that knows anything about anybody. This is CME accredited. Listen, take the online quiz and get a half an hour of free CME. Thank you, Legacy Health Systems. Because this is CME accredited, I must mention my conflicts of interests. I have none, but I would love to have some. So why don't you put some advertising on this podcast? Wouldn't it be great if this was brought to you by Pfizer? Anyway, as always, remember that basic precept, the world needs more Mark Crislip. And for that, you can listen to me on the Quackcast, an occasional review of supplements, complementary, and alternative medicine. The acronym is obviously SCAMS. I write twice a month for the Science-Based Medicine blog and my own wonderful blog, Rubor, Dolor, Kalor, Tumor. This is also a special podcast because I'm suffering from an interferon storm today. I have some sort of viral illness and my brain is foggy, my tongue is loose, and I'm incontinent. But that should not get much in the way of the podcast. Also, it's Super Bowl day. I don't give a rat's ass about the Super Bowl, so somebody please let me know who won. I have good money that says it's going to be Dallas that goes all the way this year. And now on to the literature. Now, chickens have always been a good source of infectious diseases, as well as protein and eggs. Now, chickens tend to die when you raise them, and why do they die? Well, it depends in part upon how they are caged. Now, they had a study that looked at the common causes of deaths in chickens. They included colibacillosis, erysipelas, coccidiosis, red mite infestation, cannibalism, Newcastle disease, Pasteurella, and botulism of all things. Now, here's the quiz. Which was more likely to cause these diseases in chickens? Free-range chickens or caged chickens? I gave a pause there. The answer is free-range chickens. So although your chicken may be wandering around having a good life before you turn them into KFC, it's also increasing your chance of getting an infectious disease. So remember, if you want to have a kinder, gentler chicken raising, you'll probably increase the chance that those animals will have infections or die of infections. Remember, no good deed ever goes unpunished. I have a great deal of respect for epidemiologists because it's very difficult to tease out etiology of disease looking at populations over time. There's the potential for so many uncontrolled variables. This has been part of what keeps the mercury/thimerosal cause of autism debate ongoing, because epidemiologic studies are always filled with potential confounding variables. However, they consistently show no relationship between thimerosal and autism. This study was done out of Italy, where they randomly followed two groups who were exposed to different amounts of thimerosal in vaccines and found that the amount of thimerosal did not correlate with autism in any way whatsoever. In fact, there was only one case of autism in over 1,700 kids compared to the rate of about 1 in 150 that is supposed to be occurring in the United States. Suffice it to say, there has still not been a study that shows a relationship between the mercury in vaccines and the subsequent diagnosis of autism. I've never been a big fan of wearing neckties. And yet another study shows that from an infectious disease point of view, that's a good idea. This study looked at the difference in colony counts between ties and shirts. I love this study because I'll give you the results here. 25 surgeons and 25 physicians. So evidently surgeons are not physicians. And they had either their shirt pocket cultured or their tie cultured. And the tie had significantly more bacteria on it. Now, no one ever cleans their tie, and the main thing they found of note was Staph aureus. Shirts, which were washed at a minimum of every 2 days, had about 50 colony-forming units, whereas the ties had closer to 100. And, of course, ties tend to dangle into the wound. You tend to touch your tie and push it out of the way. I don't see that anybody should wear ties in the hospital. In fact, I think we should all now go shirtless in the hospital. Given all these pasty, overweight, out-of-shape doctors, I think we could definitely make people need less Ipecac in the ER and give a good example to our patients as to how hideous they probably look, and maybe they should get their sugars under control. Just saying. Have it your way with the BK or the Burger King virus. This is just a little epidemiologic study where they looked at BK replication in the blood, in the urine of patients if they had a new transplant or if they were old transplants. And they found that it's unusual to have BK in either the blood or the urine after transplant has been a year or more in the past, with only about 3 to 10% of patients having that. For newly transplanted patients, viremia and viuria with BK peaks at about 3 months, but interestingly is not associated with decline in renal function. It's always nice to know when you have to worry about a certain illness, and with the BK virus it seems to be in the first year after transplant. The problem with influenza, well, one of many problems with influenza, is that it undergoes antigenic drift every year, so that every year we have new strains circulating that are immunologically different from the strains from the prior year. That's why we have to get a flu vaccine every year. So every year they have to come up with their best scientific guess as to what strain should be represented in the flu vaccine for the upcoming year. And it takes months to develop a flu vaccine. It requires one chicken egg for every vaccine dose. So you can imagine that you have to lay a lot of eggs and get them infected to get the flu vaccine up and running. So it's a real logistical problem with a long lead time before you get the vaccine out. And if you choose wrong, people may or may not get an optimal flu vaccine coverage. This was looked at, and they followed a total of 841 patients who received the flu vaccine in 2006 to 2007. And they looked to see who developed flu. In this study, 40% developed flu. And it turned out that the more mismatched the virus was to the vaccine, the more likely they were to get flu. Only one patient got the flu who got a well-matched immunologic vaccine, whereas all those who got B had a mismatch to the vaccine. They put the overall efficacy rate of the flu vaccine at around 47%, primarily because of a lack of match between the antigenicity of the strains infecting the population and the antigenicity of the vaccine. If we could get a better match, then the efficacy of the vaccine would be much better. Hopefully someday we'll get away from chicken eggs as a source of the flu vaccine and move on to genetic recombinant technology to develop the vaccine. They've been promising this for years. I don't know where it stands, however. Using epidemiology to try and determine the efficacy of the flu vaccine is even difficult in a placebo-controlled trial, as the Czechs determined. They wanted to see how good the vaccine was. So they did a placebo-controlled trial. Unfortunately, they did it in a year when there was a low attack rate for influenza and a bad mismatch between the vaccine and the circulating influenza B strain. As a result, they could find no efficacy in the vaccine. Given that vaccination of influenza is above all a population-based intervention, you're probably only going to be able to show efficacy if you have a good match between the vaccine and the virus during a time of high attack rate, given that even under the best of circumstances, the influenza vaccine is not 100% efficacious in preventing the disease. One of the reasons that infectious diseases is the coolest of all the medical subspecialties is how it is found in all parts of the entire universe. There's nothing that doesn't have an infectious disease association somehow. Now, there's a disease in Belgium, there's an obscenity, Belgium, called Nephropathica epidemica, which is a rodent-borne viral disease that is the most important cause of infectious acute renal failure in Belgium. Now, this has been increasing over the last decade. I wonder why. Well, here's what happens. When you have warm falls and hot summers, you get an increase in the deciduous broadleaf trees in that part of Europe. Those then make seeds. Those seeds are eaten by voles, and voles are the reservoir for a hantavirus that in turn passes this virus on to humans to cause acute renal failure. So, this is one of these global warming phenomenon where increasing temperatures lead to a change in the local environment and the local ecosystems to increase the transmission of hitherto rare illnesses. There was the same confluence of phenomena in the four corners of the United States where there was some seasons of increased rainfall, which led to more seed production, which led to an increase in the mouse production, combined with humans moving out into the desert with more exposure to mice, and voila, you had a lot of hantavirus infections. They've seen less because of the drought situation, in part, that's occurring in the American Southeast. I like the fact that my governing bodies are up to date. 25 years into the HIV epidemic, they're finally recommending that everybody who's at risk for HIV be tested. The CD recommends anybody between ages 13 and 64 be tested for HIV, and that the only people who shouldn't be tested are those who are low risk. Well, who the hell's low risk? I think anybody who's human is at risk. And I've noticed this ongoing tendency of people to lie about their sex lives. People lie about sex, people lie about drugs, and people lie about rock and roll. I mean, somebody's buying those Britney Spears CDs. So I think it's worthwhile that anybody get tested for HIV, and it is cost effective in this era of heart where we have shifted the disease from almost certain death to pretty much a chronic illness. So remember, check your HIV, especially on that priest who's in your office. There is a lunatic fringe out there that thinks that HIV does not cause AIDS. It does. And if you have HIV, you should seek care and be compliant. This interesting study looked at 543 participants with HIV. 60% of them missed their visit in the first year, and they had double the mortality rate of those who were compliant with seeing their physicians. HIV frequently occurs in a population that has poor resources, and it is always the question as to how much we are able to follow up on people who miss their clinic visits. But if you do have a newly diagnosed HIV patient who isn't following up, you should make some effort, if possible, to get them to come in. Of course, they live on the street and don't have phone numbers. That can be a wee bit difficult. One of the ongoing themes of this podcast is the importance of adhering to standards. In this particular study, looked at hepatitis C outcomes and virologic outcomes. And if patients did not get at least 85% of their pegylated interferon and ribavirin, they had a worse outcome in terms of viral suppression. As always, following the guidelines gives you the best results. It's important not only to be compliant with your adherence, but to be adherent with your compliance. However, you don't have to be adherent with your adherence or compliant with your compliance. A study out of Spain confirmed something we've talked about, the royal we, in other podcasts about the efficacy of the new vaccine for strep pneumoniae. They used this in children and adults in Spain and saw a marked decrease in diseases caused by the strains covered by the vaccine. There was a 137% decrease in invasive disease from 31.6 per 100,000 to 13.4 per 100,000, which is pretty impressive. But the cool thing is that the number of organisms that were resistant to penicillin and multi-drug resistant strep pneumo also fell. And this is because the strains that are most likely to cause disease are also those that are most likely to be resistant to antibiotics. Unfortunately, they also started to see this ecologic niche filled by other strains not covered by the vaccine. So resistant strains will come back. They will, however, not be the ones covered by the vaccine. There are those diseases that you call of historical interest. One of those had been Haemophilus type B invasive disease, which I haven't seen a case this century, in large part due to the vaccine. Unfortunately, not everybody's getting the vaccine. In part, there's been a shortage of Haemophilus type B vaccine, and in part, there's some wonky people who think vaccines are evil. There was an outbreak in Minnesota of 5 cases of invasive Hib disease, one of whom died. Turns out 3 of the 5 who didn't get the vaccine didn't because their parents were stupid. They didn't believe that the vaccine should be given and was declined. The other 2, including the one who died, were due to inadequate vaccine availability. In bad economic times, people lose their jobs. In medicine, we keep our jobs, but nobody can pay for our care. I'm excited by the people not getting the vaccines because not only will I get to see diseases that I haven't seen for decades, like Haemophilus type B and measles, but maybe I'll get some income generated in the process. So don't vaccinate your kids and keep me employed, or at least reimbursed. Streptococcus aeruginosus is an interesting bacteria. As you probably know, it smells like caramel corn or butter, and it makes in high amounts the same molecule that gives butter its buttery flavor, or microwave popcorn, that butter smell, or that taste of Chardonnay. It's all the same molecule in Strep aeruginosus. And it's also the Streptococcus group that causes abscesses. If you see a Strep aeruginosus or a Strep constellatus in a culture, you have to worry that there's an abscess somewhere. The problem with this bug, like all other organisms, that resistance is increasing. This study was out of Germany, but I think it's probably equally applicable to the United States, where they had 13% of organisms had a intermediate susceptibility to penicillin with an MIC of 0.12. And they found about 6% of their organisms were resistant to macrolides, with also some resistance being seen to ciprofloxacin. So these oral and gastrointestinal streptococci are, not unsurprisingly, often resistant to antibiotics, and your lab may not do susceptibilities unless you ask them. Certainly if it's a bloodstream infection, you should make sure that the MIC is indeed susceptible to penicillin. Last week it was hepatitis E coming from swine. This week it is MRSA. Other reports in prior podcasts have talked about the fact that swine can carry MRSA, and now this has been reported in the United States as well. In some studies, they found up to 70% of swine and 64% of those who were, quote, I love this term, caretakers of swine had MRSA. Caretakers makes it sound like they're bringing them breakfast in bed, and I can just imagine this pig wearing a shawl and bifocals. Anyway, there are probably more swine in this country than there are people, and there are probably more swine in the world than there are people. And it's an important reservoir for all sorts of infections, are domesticated and wild animals. The question keeps coming up, should we be screening our patients for MRSA, especially preoperatively? And I remain uncertain. The reason is how you're going to screen. If you just do a... I'm sorry. I think I'm going to keep that in. Oh, God. You don't get that in the other podcasts, do you? Anyway, the problem is if you're looking for MRSA, up to 25% of patients will carry staph in just their nose. Another 10% will have it in just their stool. So what you going to culture? The throat and the nose and the stool? And if you're going to use a single swab, at what order are you going to use it? This study was published in the Archives of Internal Medicine, and they also looked at 3,400 people and found that 12% had exclusive carriage of MRSA in the throat. What were the risk factors? Age less than 30 or exposure to the healthcare system. But still, 12 to 25% of MRSA will only be found in the retropharynx, and if so, doing a nose swab isn't going to be helpful. I'm still of the old school opinion, independent of outbreaks, that the best way to control MRSA is to practice fastidious infection control practices, such as, washing your hands appropriately, and maybe not wearing neckties. But I'll do anything not to wear a necktie. Until Sunday, February 1st at 4:05, I was pretty sure that vancomycin by itself did not cause ototoxicity. However, we've been pushing the vancomycin levels because of higher MICs of staph, and this study looked at audiograms in 89 patients who'd gotten mongo doses of vancomycin. Depressingly, there was a significant amount of high-end hearing loss in this population. If you were in the elderly group, here are depressingly 53 or above, and I am now 51. They had 19% of people had some high-end hearing loss on audiograms. So I think we can no longer be sanguine that when we push these doses of vancomycin, especially in an older population, that we're not causing some sort of hearing loss. So what are you going to treat them with? I've been recently going more with daptomycin for these high MIC MRSA because there was no bloodstream linazolid studies, but there is one now. This one looked at catheter-related bloodstream infections and complicated skin and soft tissue infections, and patients who received either linazolid or vancomycin. And surprisingly in the study, if they had an MSSA, they got oxacillin, and it was non-inferior. So linazolid was every bit as effective in curing the patients with the same mortality rates and side effects as patients who got either vancomycin or who got oxacillin. The cure rates were 90% in each group, and 10% in each group died. So, pretty good. There is one part of the study, however, I think it's worth quoting, which is at the very end of the study. The study, including design, management, and statistical analysis, was supported by Pfizer. The authors had complete access to all the data and final control over the content review and submission of the manuscript. Editorial support was funded by Pfizer, and everybody on the authored list gets money from Pfizer. Does this make me disbelieve the study? No, it's a pretty well done study. But still, you always have this nagging doubt in the back of your mind that the person who pays the bills gets the results they want, and there's data to support that. And it's probably why this podcast is not sponsored by Pfizer. But wouldn't this be a perfect place for a Pfizer ad? Probably not. But I think it's safe to say at this point that when it comes to treating MRSA, linazolid, daptomycin are each non-inferior to vancomycin. Whether you can say that they're both the same, of course you can't. The associative law does not apply to clinical trials. I often get a question from patient, "Hey, Dr. Crislip, how come you're not wearing a tie?" Actually, no one's ever asked me that. But they do ask me how come I get infections. And why people get infections is multifactorial. There are 3 articles out this month, and they're referenced in the reference section of the podcast, that look at mannose-binding lectin. Mannose-binding lectin binds to the carbohydrates of pathogens and activates the complement and other wings of the immune system. And there are several new articles out that then confirm that there are increased risks of infections if you have polymorphisms of your mannose-binding lectin, which also go along with prior studies to show that low levels of mannose-binding lectin, or NBL, we don't have an NBL team here in Portland, are associated with increased risks of infection. And you can check this clinically. So if you have a patient who comes in with recurrent infections, one thing to check, especially if it's respiratory infections, is immunoglobulins and subtypes, which is a very common immunodeficiency, but it may be worthwhile checking for MBL levels, although polymorphisms, I bet, will play a bigger role than absolute numbers in problems with this particular serum protein. Take-home message, MBL is not MLB, and that either deficiencies or polymorphisms in this protein increase patients' risks for infection. I have figured that in my lifetime, I have probably eaten over 25,000 peanut butter sandwiches. There's probably no food that I've eaten more of in my day than peanut butter. That's what I subsisted on in medical school. Now, we know there's a huge outbreak of salmonella in the United States, this time and again associated with peanut butter, all traced back to a single factory in Georgia. Now, this is what I did not know about salmonella. I'm not surprised, by the way, that there's an outbreak with salmonella in peanut butter or other foodstuffs. Our food distribution system is prime for widespread outbreaks if a source should become inadvertently contaminated. And here's what I didn't know about salmonella. Quote from the CDC: "Salmonella can persist indefinitely in high-fat, low-water activity foods, such as peanut butter. And in such foods, salmonella can withstand temperatures as high as 194 degrees Fahrenheit for 50 minutes. Fortunately for me, all the peanut butter was not put into consumer products. And so Jif, which is the best peanut butter, I think because it has molasses in it, is unaffected, and I can continue in my wild consumption of peanut butter. But there'll be outbreaks in the future, if not of salmonella, of something else, if not peanut butter, of something else. Unless we irradiate our food, which is not without its own problems, we're always going to have outbreaks of infectious diseases from eating contaminated food. Salmonella. Endocarditis, of course, kills you a variety of ways. It can blow out your valve, it can cause you to be septic, and you can get thromboembolic events. This study looked at the outcomes in patients with endocarditis on chronic antiplatelet therapy. And if you came in on chronic antiplatelet therapy and you developed endocarditis, then you had lower mortality rates than if you didn't. Also, those who were started on antiplatelet drugs after admission had a trend towards lower mortality. So, you're not supposed to give Coumadin or heparin to endocarditis patients because the vegetation falls apart and they shower. But this may not be the case with antiplatelet therapy. And there's not enough data currently to suggest it, but it's certainly a study that needs to be done in a definitive manner. This confirms an article from July of this year that patients with endocarditis who are on prior antiplatelet therapy have less embolic events. So if you're planning on becoming a heroin user in the near future, which puts you at risk for endocarditis, you might want to take a daily aspirin as well. What to do if patients have acute endocarditis and they're not on platelet therapy beforehand? Your guess is as good as mine. Actually, my guess is better. Sometimes it's just the title that catches your attention. This one is the vaginal microflora in relation to gingivitis. What? So here's the abstract. Gingivitis has been linked to adverse pregnancy outcome. Bacterial vaginosis has been associated with adverse pregnancy outcome. We assessed if bacterial counts and bacterial vaginosis is associated with gingivitis, suggesting a systemic infectious susceptibility. Their conclusions: higher vaginal bacterial counts may be found in women with BV and gingivitis in comparison to women with BV but not gingivitis. So there may be a relationship between vaginal and gingival infections. For a moment, I thought we might have a candidate for the Ig Nobel Awards, but I guess not. A couple of podcasts ago, we talked about a CID study that looked at Pseudomonas colonization and adverse outcomes in patients with COPD. There's another study out there that confirms that study. This looked at 50 case patients and 50 controls with outcomes, and those that had Pseudomonas and COPD had a 60% crude mortality at 2 years versus 30% in the control group. So it would appear that in a COPD patient, Pseudomonas behaves like it does in the cystic fibrosis patients. So, how long should you treat ventilator-associated pneumonias? This study looked at the data in a meta-analysis, or at least an expert review, and you can treat VAP for less than 10 days. How long should you treat community-acquired pneumonia? Well, with community-acquired pneumonia, is longer better? Again, the answer here is probably not. You can probably treat 5 days and take care of most community-acquired pneumonias. So it's 8 to 10 days for VAP and 5 days to 7 for CAP. But unfortunately, no amount of therapy will eradicate RAP. Couple of quickies as we finish up here. If you get Candida in your transplanted kidney, you probably got it from the harvested kidney, not from the patient. It has a high morbidity and mortality with it. That maybe the gamma release assays, the quantiferon golds, are superior for screening healthcare workers for latent tuberculosis. At least they thought so in the Archives of Internal Medicine. I'm not so sanguine about that. In a small study, they looked at caspofungin for the prevention of intra-abdominal abscesses due to Candida and found it to be extremely effective. Anytime you get a perforated viscus of the colon or especially the stomach, Candida peritonitis and candidemia rates are high with double the morbidity and mortality. And the problem is increasing resistance to fluconazole in Candida albicans and a shift to non-albican species. Whether or not you can recommend caspofungin all the time would be nice in a randomized controlled trial, and was not effective with fluconazole, as shown in the Annals article, is yet to be determined. And we'll finish up with an interesting study. They went to a remote Peruvian Amazon, that should be Amazon, and looked at the E. coli in the people there. And they found high levels of acquired resistance to ampicillin, tetracycline, TMP, sulfastreptomycin, and chloramphenicol with a, quote, remarkable diversity of resistant clones and of resistance genes in plasmids, end quote. This was an area that had seen very little antibiotic. How did it get there? I don't know. There has been suggestions, as we've talked about in other podcasts, that it gets there by way of migrating birds, and it's one of the ways they found resistance up in the far north. So the resistance that you flush down the toilet today may end up in Peru tomorrow. Well, birds aren't that fast, but you get my drift. And that's it, my children. We're done with this podcast. I just got done watching Springsteen on the Super Bowl halftime, so I think I'll bring this to an end. This has been your Puscast for the last 2 weeks of January 2009. Now that you've listened to this inane babbling, take my CME accredited quiz and get a half an hour of free CME. Thank you, as always, to Legacy Health System, brought to you by Pusware, LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion. Your uber-hyperlinked electronic guide to infectious disease at pusware.com. Remember, the world needs more Mark Crislip. So listen to my Quackcast, read my blog entries, and in all things, think of me. I really think if more people woke up in the morning and said, how can I make Mark Crislip's life better? The world would indeed be a better place. Bandwidth ain't free, so feel free to purchase the compendium or otherwise send me money. Copyright 2009 under the Creative Commons license. The music is by my son when he was 12, improvising on the guitar. And as always, thank you for this most interesting consultation and allowing me to participate in the care of your patient. I will continue to follow along with you. Thank you. In dictation, goodbye.